First of all, I'd like to say thank you for coming out this evening and taking out time and, right before the holiday or right in between the holiday to share a little bit of time with us. We're going to go ahead and get ready to get started. Some people said that, well, what's the point? What's the purpose? And the purpose is honestly to have a bit of a conversation, mainly to have a conversation about how it is that the syndemic of HIV, viral hepatitis, substance use disorder are impacting our communities. I like to say from the hoods to the hollers. How is it doing it? What are we going to do about it? And what are our solutions to do it together? We're going to talk a bit about opioid settlement money. We're going to talk a bit about what community-based organizations can do. But most importantly, we're going to talk about what's the solution. One of the big challenges I think that we have here in this town in particular, but I think that we see across rural America, is really what we're going to do to make sure that we can keep Main Street open and strong. And one of the things that we have to do is to figure out strategically how it is that we provide health care and healthcare opportunities for people with lived substance use disorder experiences. Those are the people that are going to be the ones that are going to be washing the dishes, that are going to be the waiters, the waitresses, and those are going to be the factory workers and the other line workers that we see across the Rust Belt and across rural communities. So I really wanted to have a conversation with you all and about, what are we going to do? We've seen a decrease, is what you're going to tell me in a minute, in Charleston, with a number of fatal overdoses, but we're seeing an increase in the number of HIV and hepatitis C cases. And we got to figure out how those things go hand in hand. And so I'm going to start with where I always start. And where I start is we're going to do introductions, and then I'm going to tell a little story. And you are?
Megan Simpson. I'm the program director at the Greater Kanawha Valley Foundation, which is a community foundation.
What's a community foundation do?
Well, community foundation, my main job at the foundation is I help give out grants. And so grants to the community members, to nonprofits who are doing this work. So.
Thanks. And you are, sir?
I'm Dr. Stephen Boyd. I'm the director of the Office of Drug Control Policy of the state of West Virginia.
And how would people might know you? How is it that people might know you?
I hope that they don't know me.
Yes, they do. You probably owe them money.
Well, most of our stuff's out there, so I hope they don't have too many secrets out there. But, I've been really interested in this field for a long time. The most important thing about me is I'm in recovery myself, so I've lived this life. Been addicted to the drugs that we're going to talk about with OxyContin and Xanax, and got world-class help. And really, since that time, it's changed not only my life, but my career. And I'm really interested in how opioid settlement dollars are spent in order to abate the opioid epidemic. We're never going to be able to make people whole because we can't bring people back from the dead. But, I talk about this all the time. How we spend this money is how we honor those that have passed away. And so hopefully we'll get to talk about that. And then what my relationship with you is around hepatitis C and HIV. And we've got some things in place in West Virginia already that I think that we can piggyback off of. So I hope we get a chance to talk about that, because I've learned some things since we last talked. And because this is, HIV and Hep C in the state of West Virginia is ruining the intravenous drug use. That's a fact. And so, what are the things that we can do to mitigate those? It would be a terrible thing to be, using drugs for 20 years and finally get into recovery, find out you're going to die of liver failure in 2 months. And, we talk about funding for this all the time and say, well, it's going to cost this amount. It costs a lot to treat chronic liver disease in the hospital, and it costs a lot to treat HIV disease over the course of a lifetime. So I think that we're already spending those dollars. How can we allocate them to prevent these things from happening in the first place, are the things I'm interested in.
Thank you, sir. And you are, sir?
I'm Dr. Bishop Robert Haley of a Morrison Light Center Church. We also have a nonprofit called Bright Futures Now. And I guess I'm on the front lines of what we're actually dealing with. We get the addicts, we get the ones that are sick with HIV, the ones that have other situations, and we try to handle those as cautiously and as clearly as possible, but realize we need a lot of help.
And sir, you are?
So I'm Dr. Thomas Kubo. I'm a pulmonary critical care doc that has joined WVU Health System. I'm the Executive Vice President for WVU Health for Provider Relations, and then also have the honor of serving in our state legislature. Currently the majority leader of the state Senate, representing Kanawha County.
Perfect. There we go. So thank you so much. Thank you all for joining us. And now we're going to have a conversation. Now, some of you have been on what we call our Appalachia Partnership Consortium before. And so you know it doesn't go the way it usually goes wherever else you go. So let's get ready to have a conversation. I'm going to start the conversation where I start often, is this. Here's what I believe. Here are my core beliefs. Number one, that there's a train and it's roaring through Appalachia. The engine of that train is the OxyContin crisis many of us know. But now it's a poly drug use crisis. The next car on that train is hepatitis C, hepatitis B, and hepatitis A. We've got educational attainment challenges, workforce development challenges, economic development challenges, with the caboose of that train being HIV. And right now we have a sidecar syphilis, which we really need to talk about. I need you to imagine that train laden with coal, the environmental impact of coal, the economic impact of coal, and the psychological impact of lost coal jobs. Our job at Community Education Group is to be the boulder that stops that train in its tracks. We do that by bringing resources, opportunity, and attention to the plight of the people of Appalachia, and that's 26 million people, 423 counties, and 40% of those counties buttress up on one another. Why do I always bring up that 40% buttressing up on one another? Because I think that that's a key role that opioid settlement dollars can play, where sometimes federal dollars cannot fill those gaps. That's one of the things. The other thing I really believe is this, is that in this country we say that we can't find approximately 20 to 25% of HIV cases. I believe those cases are a rule of error. I believe that they're in medically assisted therapy centers, MAC providers, buprenorphine, Suboxone, and methadone, where we have to increase screening, where we cannot continue to allow people to opt out. The other thing is that we say we can't find 40% of the hepatitis C cases that we need to treat. I think that they're there too, and I think we have to increase testing. So let's start there. How do we increase testing in West Virginia and across the state to ensure that we can get people screened for HIV and hepatitis C and link them to care? And then let's talk about PrEP after that. Go ahead, Dr. Lloyd. You got the big job.
Yeah, so that sounds pretty easy. I want to be able to tie that up fairly quickly. I'm a fan of Willie Sutton, the bank robbery, and they said, why do you rob banks? Willie said, because that's where the money's at. So I'm going to go where the money is. And I've got to meet so many people in the state of West Virginia in the past 3.5 months, and honestly, I'm having a blast. The sense of community here is really unbelievable. And I'm a Tennessean. I got on a Marshall hat. That's because I just came through Huntington. But the sense of community here is really unbelievable. And the folks that I've got to meet are I just have been blown away by the system of care that's already in place here that I had nothing to do with. Bob Hansen, Rachel Thaxton, Matt Christensen, these folks have worked on this for a really long time. And our system of care here in West Virginia, I'll stack up against anybody. And in all honesty, I didn't believe that coming in here. I've got a relationship with Dr. Kubo. I've known him for a good while. And the things that have been done by our legislature, our governor, the people who are working in this field, really to me is unmatched in anywhere that I've ever been. But we've got some gaps that we need to start to tie together. And so I met a doc the other day from WVU, Dr. Feinberg, brilliant infectious disease doc, and I loved everything about her, and she's feisty and a fighter, and I love all that. And she gave me a stat, Mineral County, West Virginia, through all of the HIV epidemic from the early 1980s, and some of you are too young in this room to remember what HIV was at that sentence, but I remember it. So from the start of the HIV epidemic all the way until recently, Mineral County, West Virginia, had 0 cases of HIV. 0. Now it is the second leading county in the state of West Virginia in new HIV cases. And guys, it's exactly what Tony was just talking about. It's driven by IV drug use as well as Hep C. So, what can we do right now? And I agree with Tony. I said, these cases are out there, and my guess is we're already touching them. I think we're already touching them. I think we're touching them in DCR. And I want to talk about DCR. Sorry, so many things here. But DCR, the work that's done in DCR here, I think Department of Correction and Rehabilitation. And I'm having to learn all the acronyms, guys, so a lot would mess them up. But we actually provide drug treatment behind bars in the state of West Virginia. It's amazing. And so is that a place that we can look to increase screening for these? Absolutely. I mean, that's one touch point. Other touch points, we have programs in our emergency departments all across the state of West Virginia where we intervene on people with substance use disorder and link them to treatment. It's amazing. What are we doing in screening in those cases? And then the last but not least is a program that I learned about just today, Project Engage. Where our hospitals are actually, doing this work. So what are we doing in screening these high-risk individuals? Because we know, I'm sorry to be graphic, if you're putting a needle in your arm, you're at risk, right? And if we've got somebody in front of us that we're trying to get into treatment, to me, part of that treatment is screening for these chronic diseases that we can do something about. If they don't have HIV, then we've got some things that we can do to prevent that, things like PrEP. If they have hepatitis C, guys, that's curable now, and it's paid for by Medicaid. And if we don't address this and we're paying for it down the road, it's going to be, even if you don't care anything about people, right, it's going to be way more expensive to treat it on the back end than it is to treat it up front and prevent it in the first place. So I think we've got the touch points, and I think the touch points I see are in DCR, in our jails and prisons in the state of West Virginia, and the people who are showing up at treatment centers, outpatient MAT clinics, hospitals, both the inpatient service and the emergency department.
Perfect. Doc, I'm going to turn to you. So we got two things that I want to talk to you about. One, I want to talk to you about, and I don't mean to put you on the spot, but I want to talk to you about the fact that we had not been able to get any legislation to increase the number of OTPs in the state of West Virginia. So we've got, We've got 9 that are here, 7 is owned by one company, and 2 are owned by another company. I think that if we had more opportunities for these touch points. That's question one. I got 2 coming to you. And the second one that I want to ask you is, can we start to think about a requirement where these MAT providers have to screen, or we don't? I mean, I don't know if we get to a place where we say, if we let you opt out, then you say no. Then we don't screen you for HIV, then we kind of miss the problem. We miss the very touch point you're talking about. Can we require people to be tested for HIV and Hep C? And the OTP moratorium.
Yeah, so the moratorium, the problem we found in the legislature is there's a lot of misconceptions, and there's a lot more education that needs to be done for legislators. And so many of them come in with the predisposition of what they see out on the street. They don't see what's happening inside rooms like this and all the churches and the community centers and the other parts of it, and they don't see the results when people are successful with it. And so there has to be a better job of communicating and educating our legislators so that they have a better understanding of it, and they know that it's not just this horrible, they're only looking at the dark side of it and not the other. In terms of testing, it really depends. I mean, it's one of those things that you can't, right now our legislature's real strong on free. You can't force somebody to take a test, right? And it's always better to treat, go after problem carrot and the stick. So if I think you surround these people with support and you show them that you're wanting the best thing for them, and they understand that, feel that, the hope is they would do it on their own, right? And that is the approach I would try to take.
Is that so? What do we do though? Because if we continue to let folks opt out, I think we're going to continue to round back to this. Now, you guys, are you funding any of these programs to support HIV, Hep C as a part of the substance use endemic, or where are you? What are you guys really seeing, even in the applications, I guess, that you're getting?
Just the need. I think things that we'll fund around, just like the getting tested. We can do those, fill in those gaps to just do like like some type of incentive, like gift cards or things like that, that we'll hear, that's helpful with things too. But yeah, I mean, around this, the need, we're overwhelmed. I mean, we can't respond to it at the level that it needs to be. But I think we're able to go out and listen to our communities and how maybe as a community foundation, maybe we can't fund a huge project, but we can do pilot projects to show what can work.
And so what are the type of projects? So because maybe people don't know it, what are the type of projects you guys fund? Because I mean, I don't know all of the projects we fund. I mean, you say a pilot project. Would you fund a testing day? Would you fund a Narcan day? Actually, I don't know.
We funded all those things. I think what's nice about us as a community foundation is we don't have as many guidelines as maybe like a federal grant does. I mean, back in the day, we were able to fund, the needle harm reduction projects and things like that too. So we have a really great opportunity to work with the folks that are on the ground doing that work and really coming in. We're not the experts. We listen and then
how big is the community foundation? Like, how many grants do you guys give away a year? How much money do you guys give away a year?
Several $1 million.
Several million.
Yeah.
Okay, so
in our discretionary.
In your discretionary. And so, what are your funding priorities? I'm just trying to help the people figure out how to come get your money.
That's like and I think a lot of folks here refunded before too. So really, we have program officers who are on the ground that work in education, health, community, economic development, basic needs. And I think every type of grant that we fund, you can tell has been impacted by the epidemic.
Sure. Don't know. I'm going to take the question you give Senator Kubo. I love this answer, but I want to talk about this a little bit more. Yeah, I got fired up. Right. I stay fired up. Yeah, I would challenge the OTPs in our state to be more than a medication distribution center. There's more to recovery than writing somebody a medication, and I've been in front of our legislature several times, and I have yet to find anybody there that wants to harm people. Not a single one. And more that we can get, our legislators to understand, just like Senator DeCulo just said, about what we're talking about. And so, we've got an OTP moratorium. Do we need more? I don't know if we need more or not. We need more effective ones. I know that. And this, guys, the opposite of addiction is not recovery. It's community and relationship. And the OTPs need to be a part of our community. I like to think of it as an integrated medical clinic where you come in and you're right, the medication saves people's lives. We all know that. It cuts down on cravings and it keeps people alive, and I can't treat dead people. So that's a good thing. But what are we doing outside of that? And one of the things when you start talking about screening for HIV and Hep C, this is just my experience. I'm not a Hopkins public health guy. I didn't go to Yale, none of that stuff, but I've talked to a lot of people with addiction, and I've been there myself. And the fact is, when I was in the throes of my addiction, I didn't want to know. I didn't want to know because I didn't know what was on the other side of that. And if you're sitting here and you've been using a needle and you know that you've shared needles with somebody and you know you're at risk, the fact is you don't want it up. Because, first of all, HIV has been a death sentence for most people's lives. It's been a death sentence. It's not a death sentence anymore. And hepatitis C, we did not have a cure for hepatitis C. We had interferon, and heck, the interferon was worse than having the disease. And now we've got really good medication that you can take for 12 weeks and you're hepatitis C free. So I agree with Senator DeCuvo. I like the carrot out there. And that's us being in front of our patients going, hey, this is what you're at risk of, and this is what can happen long term. And guess what? We've got a treatment now, and your insurance covers it. All right? And let people know that there's actually treatments for this. And if you slip up, right, we have some things we can do to prevent you from getting this in the first place. And so I think I like the carrot approach. And sometimes we got the
carrot, though. Tell me what the carrot is.
The carrot is that patient now understands, one, they're at risk, and they may or might not understand that. We've got to overcome their denial about what they're at risk for by showing them that there's a cure and hope on the other side. That's the carrot. And I think you can get there.
So how do we engage? Where do we start engaging? Because what do I engage when I'm doing the syringe exchange? Do I engage at the medical appointment? Do I engage when they come to church? Where do I engage them?
All the above.
Huh?
Can I say something real quick?
Say anything you want.
These guys were the experts and everything, but in dealing with people, and he was just saying that, they get them when they come to jail or in the correction system. Well, we get them when they come to eat. We have one of the largest food distributions in Charleston. We feed over 300 some people. In the midst of that, with partners, and that's the whole key. Partner with people that, like you guys, to get the work done. And we partners with Health Right, now Walgreens, and a couple other folks right in the midst of our food distribution. They can pick up their box of food, they can go next door, they can be checked for HIV, whatever they may have. They can go to Walgreens, get their flu shots. And this is every month. We do this once a month, first Saturday of each month. And I guarantee you, and one of the problems we don't share data. See, I got some data that you guys probably could need and use, and I'm sure some of these others got data. We don't have one place that we can come, or you guys go to, and some more data is there for you. So those are the type of things that's going to help us better ourselves. The more data, the better off you are. We've been at this for 6 years in our location. Came to a point during the beginning of the AIDS crisis that we were, matter of fact, CEG helped us a bomb and some other folks. We were putting food out on our parking lot, and the homeless was coming up. We never told them that if they didn't get checked, that they couldn't eat. We just put the food out there. The Health Right was there, and they were taking, we're getting 25 people, at least 25 people per time we were out there. So we did that for, I think, about 6 weeks. I don't know where that information went to, except the one that we had. And we'll freely share whatever we had. But a lot of times, I want to say to everybody, don't be scared of the church. We're there. We're in the community. We're doing the things. I just telling the gentleman the other day, I lost a young man at the end of November. That was one of my, first November, which was one of my main helps there at the church. He would come, and anything I asked him to do, he would do it. He left after a distribution day. Left after we got through, and I was expecting to see him the next day. He went down the street, around the corner, and never came back. He died right in the streets of Charleston. And that hurt me, but it impacted me in a certain way, is that we can't sit in our church and not do something. We can't say we're part of this community and not reach out and really hit and touch people. I came to church one Sunday, and I got the picture on my phone when there's 3 surrendered needles sitting on the church. The first thing I did is I flew angry. We didn't realize they were not used. So somebody was going to use these drugs or use them for drugs, and they just left them at the door. So that's the presence we got to have. We can't sit up in our buildings. We can't sit not attached. Like you said, we got to get in the community. Got to walk the community. I'll walk with you. There is some real people out there that don't want to be the condition they are. And like you said, I didn't understand what addiction was until I talked to somebody who was addicted. And she basically said, you don't know what it is to lay in your bed and that thing cries for you, calls you and pulls you. And that's the state we got to get in, because if you ain't never been there, you can't really speak to it.
Bishop just did a great job of describing something called contingency management. That's one of the best descriptions I've ever heard. And he probably doesn't know that till just now, but it's extremely effective. And I'll laugh, and I know Dr. Kubo will back me up on this. If you want to get doctors together, feed them, right? They'll come. And so I think that you can use things like that. But, getting to them up front and letting them know, these things for so long. Hepatitis C, we used to treat it back when we were in training. It was terrible. Right. And that doesn't exist anymore. It ain't nothing side effect free, but there's good treatment for it. And HIV is not a death sentence. But, that's why I like doing things like this, because I love that idea. And we get to them there. I think it's a great idea.
But I want to come back to you for a second. How do we educate those legislators, right? How do we get them in a room like this and from behind the dais, right? And say, we just want to have a conversation. We not no judgment, no nothing. We just want to talk to you and give you the new information about what the new treatments are, what the new things are, what's out there. How do we get them out here to get a stuffed mushroom and a puff pastry chip with some pesto? How do we get them in a room like this? What do we do?
So some of this is like what you're doing here, right? So one of the things I've talked about for a while is we've got to tackle it from two sides. One, people like to come down to the legislature during the legislative session of 60 days. Now, those guys are drinking out of the fire hose. I mean, there's so many things going on, so many. That's not the time to build a relationship and get an understanding. So what I tell folks is try to do the reach out during the other 10 months of the year. Get a one-on-one. When you get big groups, you lose people. If you're able to get them one-on-one where they can actually get down into the weeds, see it, get more of a granular deal for things, that sticks better. But from the other side, it is going to be data. That's what we've been pushing for, dashboards and to give the tools to the toolbox. A lot of the guys here, I've always felt for the past several years had to work with their hands tied behind their back because the state hasn't given the support and the tools they needed to be as effective as they could have been. And so we're still in that situation. We've got to have data. We've got to have dashboards. I mean, I literally, when I first got elected about 10 years ago, one of the very first things I ever did was I came to a thing here in St. Albans on OVA. And back then, 10 years ago, I said, I walked away from that, and you realize that there needs to be very comprehensive websites so that it doesn't matter if I'm a kid in grade school doing a project or I'm a parent, a dick person, or I'm addicted myself. I can go to that one site and I can get involved with the community, get help, get information, get educated. I still don't think we have that really built where it needs to be. There needs to be a section on that for communities. So that I've said that the communities need to have access to, so that if there's something like this going on, that you could be posted about it, get more people, get them educated. State needs to help with that. A lot of resources are tapped. So there needs to be education from the legislators from data so that they know when we're going and we're trying to tackle these problems and we're saying, hey, listen, we need to spend this money. A lot of come back and say, the problem's only getting worse. We're throwing this money away. Well, if we have data to share what works, what doesn't, help the West Virginia First Foundation, other people to know where to direct those money so we get the most bang for the buck, that's education. Getting them on a one-on-one's education. Getting websites and stuff built and usable and user-friendly that everybody can access and get some of the front, that's education. So it's a multi-pronged tactic you need to do.
But wait a minute, before you go somewhere else, because I saw you. I know you. I know you well enough to know what's getting ready to happen. So here's the thing. That's one of the things that I'm always confused by. And maybe you know this and maybe you don't know it yet. What's the state funding when it comes to the syndemic of HIV, hepatitis, and substance use? Because the state doesn't really put out like a bunch of grants for this. I mean, they put out grants for, this, that, and the other. But we really don't see grants for this.
So I started here.
No.
I'll answer the question. I got some people in the room who can probably answer that.
He's gonna say, "I'm retired now."
He slid over behind Rachel. Said,
Let's all do that.
And it's okay, but don't worry. I want to speak to it because it is important. Because I think I'm not on the West Virginia First Foundation. I watch the meetings and I answer questions when I'm asked, and I really like Jonathan Board and our chair as well. But I'll answer those questions.
But wait, I don't want to. I'm rude, and so I'm interrupting you. But you knew this was going to happen anyway. And is that I think the opioid settlement question, opioid remediation funds question, is a different question than state funding.
It is a different question,
Okay.
and I haven't been here long enough to know the answer to that question, and I just haven't, and I'm sorry. But maybe somebody in the room has. Is anybody in here can answer that?
Commissioner?
I know that that's more of a question for the now Department of Public Health. Department of Health. But I know that they do some of Brian White. I don't know if that's a grant, but I know that there's some mobile Brian White. And they said down 80 testing. The Bureau for Behavioral Health, infectious disease is not our bailiwick, so we do not have any grants related to HIV or Hep C. Now we do fund some, but as far as grants that are explicitly related to infectious diseases, that's not something that my bureau does.
And I don't know the answer for that, and I'll get you. But I do want to
Say something that Dr. Takumbo was just talking about. I've been here since the last day of August, and it's amazing to me how many times I get a call from our legislators to come over and talk to them about this. So education is happening. It's happening now, and it's getting ready to happen this coming weekend with the interims, because I already have a couple of appointments where legislators have asked me to come and educate them on certain issues. So that stuff does happen. And I agree with Dr. Takubo. It's got to be in there when you get into session. I mean, there's a lot of things going on. But in this time of the year where we're not in session, there's some really good things that can happen. And like just a few weeks ago, we got together and talked about how we can better serve our women who are substance using and pregnant. And I thought it was very fruitful. We had lawyers, we had members of the House of Delegates, we had at least one state senator, Vince Deeds, there. And so I think these things are happening behind the scenes, and hopefully I can continue to be a part of it, because I'm very interested in that and what we can do going forward. When we start talking about funding in that part, I don't know that. I think these are things that West Virginia First Foundation needs to look at. But you're right. I mean, and sometimes we get siloed. It's like Nick just said. That's not in I guess in our silo in ODCP. But the one thing I like about ODCP is that we can move in between those silos. So as I go on in this job, those are things that I'm looking to do, because I need to talk to our people in the Department of Health and in infectious diseases and see what we're doing around these, because these things are intimately tied together. When we know our cases of Hep C and HIV are coming from intravenous drug use, we can't stay siloed there.
Right. And what about you? Are you guys funding any kind of infectious disease programs, HIV programs? Do you accept those types of grants and opportunities?
We do accept those types of grants. Currently, right now, no, nothing specific to HIV. We have some kind of street medicine where they're going around and testing folks and working that way. So,
one of the ways in which I think we even kind of really got started of addressing the syndemic, and a syndemic is multiple disease states kind of impacting an individual community, city, state, jurisdiction all at one time. HIV, hepatitis, substance use disorder, is that I looked at, or actually somebody sent me, I'll tell you a story because, I always got a tale, is that someone sent me a copy of the MMWR, that's the Centers for Disease Control's Morbidity, Mortality Weekly. It tracks deaths and other things, and they usually have some sort of internal reports. And it was the 220 most vulnerable counties in the United States of America. And I remember I was sitting on my porch and I looked at it. And of the 220 counties on that list, 28 of West Virginia's 55 counties were on that list. And I remember I called my friend back who worked at the Department of Health and Human Services and said, well, what'd you send this to me for? And she said, well, you're the only person I know in West Virginia. And I said, well, okay, that's great. So the next couple of weeks, and I can't remember if it was a week or a month or what happened, but the next thing that happened was that the Wall Street Journal had an article. And the cover of this article, a cover story was this kid in a WVU basketball jersey. Sorry, Marshall. And he had on some WVU basketball shorts. And the headline read something like, "The Hepatitis C Crisis to Cripple West Virginia Economy." Right? And I was like, oh my goodness, they told the story. They said the thing out loud, right? Which is that there's a direct correlation to what is going to happen with hepatitis C and Main Street, right? I mean, because it was really about the story about injection drug use and how injection drug use was going to lead to hepatitis. But the thing I kept thinking about when I was reading the article is that it talked about an 800% increase in hepatitis C over the last decade, right? But then what it didn't talk about at the time was the likelihood that HIV was going to rear its ugly head, which we all know in public health has to happen because we had what? Drug use, we had hepatitis C, we had low rates of employment, we had high prescriptions for opioids, and we also had folks that were unemployed. So the next thing that had to happen was going to be HIV. So one of the things that I keep thinking about or asking myself is, when do we decide that we're going to do this different? When do we decide that this is a problem for us? I was talking to someone the other day, and the question came up about, when do we realize that it's not them, it's us? It's not a gay problem. It's an injection drug use problem. It's a rule problem. But the thing is that in many cases, the people that we're talking to don't see themselves in the advertisements. They don't see themselves in the communications. When we talk about PrEP, most people don't see themselves as a part of the PrEP solution. What are you doing with PrEP in this area? You see how I did that?
The thing there's people in this room that have been to talks that I've done around the state and really around the country, and when I talk about this issue is that this thing does not exist in a silo. What we would all like to think is that nobody in this room is at risk of Hep C or HIV because we don't use intravenous drugs or we're not a home set. All right? That's what and that's not true. Your risk of hepatitis C and HIV is directly proportional to the viral load in this community. That's a fact. If you have a car wreck out here and they go to the hospital and they're going to give you blood, they're going to make you sign this thing on the computer that says your risk of getting these two diseases from the blood transfusion you're getting ready to get. It is not zero. I promise you it's not zero. And that number on there is directly proportional to the viral load in your community. And the point I'm trying to make there is that we are not insulated from it because we are all at risk. It doesn't matter because these things can happen. Our family members can be in it. So we have to make this an issue that we are at risk and we don't live in this vacuum. And if we don't control the viral load in our community, then we raise everybody's risk, our own risk as well as our family members' risk. And so that's really how I try to approach it. And what you're talking about, one of the things that happened in Scott County, Indiana, right? You got this little bitty rural county in Indiana that has a high rate of intravenous drug use and a high rate of Hep C, but almost no HIV. And all you need is one person getting in that community, and then now everybody's got it. That's where all of this come from. And that's actually where the word syndemic came from. And so if you look at the counties at risk, almost half the counties in West Virginia are at the top of that list. And so I think we have to pay attention to it. We have to be talking about things like PrEP. Because in all honesty, I learned about PrEP when I met you. So, that's true. I did. And so, but now we have something to offer our patients, right? They're scared. They don't want to know. And I think that's part of, we're talking about the OTPs. We need effective OTPs that are building relationships with patients and that can educate them on these things and see the things that we can do for them rather than having coming in, handing their methadone and hitting the door. And I think that's what our legislators have a problem with. In all honesty, so do I.
Well, I think that that's it, right? So I say this. I believe that it's about our social networks, our sexual network, our drug sharing network, our faith network, our familial network. And we have to do two things. We have to disrupt those, right, with testing, linkage to care, and education. But we also have to infuse information into those, your level of risk, your level of understanding, your level of awareness. But we also have to do another bigger piece, is that if I go to Jim Bob and Billy Bob and Mary Jane and Mary Sue, and I say, hey, guess what? I want to talk to you about this. I can't send them to a PrEP website that's got somebody that is just going to have them go, I'm not one of them, I'm not one of those, right? So the dashboard that you're talking about, the dashboard that really needs to be, I think, something that speaks to this community. And what we haven't been able to do, I think, is go en masse to people and say, no, we have a need. Rural communities have a need. People who use drugs have a need. People who are in risk of these things have a need. And when I say these people, I think often we are in meetings often with large pharmaceutical companies who tell us, you know what, there's no problem there. You're a canary in a coal mine. It's just you. Really, you're the only one talking about the people of Appalachia. Please go away. Don't come back here no more. Get after it. And so I'm going to need you guys to go with me and you to go with me and say, no, there's a problem. It's not that she's, well, I was going to say not that she's crazy, but that is not going to be, we hit up. But so help me understand what we're going to do and how we're going to get maybe some of this opioid settlement money to get out here and do some of this work, because we don't have any grants. We don't have anything else. How are you going to go convince them to give us the money that?
Well, I can't. It's not part of not part of what my job responsibility.
250.
Well, I think that I know a lot of people on the West Virginia First Foundation. I know where they're coming from, and I think presented in a grant application, when they do have an open grant application. Rachel's sitting in the room. I mean, Rachel.
Hey, Rachel.
But Rachel understands the significance of what we're talking about. And Matt Christensen is on that as well. And Matt, for sure, as our state health officer, knows that. So, it's going to have to be a group that can put forward the grant proposal that lays this out, because this is a priority. And I don't think that we're overlooking it. I mean, I try to give a voice to it everywhere I go, because it is a risk, and it is going to impact our state's bottom line. I mean, there's two ways to look at this. You care about people, or you care about money, and sometimes you care about both. And if you don't care about people, our state's bottom line is going to be affected by this. Because, Dr. Takuba will tell you, taking care of liver failure patients in the ICU is a recurring process that costs a lot of money. And so as we get people to understand that and see that we could treat it and prevent that, then I think that's a benefit. And I think it shows a positive return on investment. And I think we have some things in place that we could do that, as far as what you're talking about. And we need an organization that's giving this a voice, and you're certainly doing that applies for this grant money. And then let's start measuring outcomes. And let's start measuring how many cases we prevented and what that prevented downstream, so that we can show a return on our investment. And I think that's how we go forward.
100%. And I think that one of the other challenges before us is to really figure out how we do this, but we make sure that we do it across community. And like I say, it's not that one person or one group gets everything, but that we're doing it together. And I have another real thing that I believe, and I got a whole lot of core beliefs, that, is that I feel like the other thing that we've got to do is, at some point, we've got to figure out how we address community level trauma, right? And when I say community level trauma, sometimes I think about the legislator itself, right? The body, the individuals that make it up. We in Appalachia have been dealing with the opioid crisis for 3 decades. You got to tell me that those members are not traumatized in some way? Family member, cousin, brother, person they went to high school with. How do we begin to have a conversation with them about what's my experience, my individual experience as an individual, as a human, as a person, not a member of the state house? But if I'm making decisions based on a traumatic experience I may have had, it's different than me not having that conversation with you or me or someone else. I don't know if I'm making a little bit of sense there or not.
Yeah, the question is, you got situations like in Logan County where 70% of kids are being raised by not a single biologic parent. You got classrooms in Boone County where single parent wards, either they're dead, incarcerated, dead, and so it's tough. Everybody likes to say negative things about the education and stuff in West Virginia. The reality is, teachers of the state's probably got the toughest job of about any profession you can see coming along. They're counselors, they're teachers, they're so witty other things, but the reality is you're going to have to figure out a touch point for some of these kids. And we have tried to, in recent years, pass legislation to put more counselors, more individuals in schools. Teachers can't be expected to do all this. They're going to have to help. We've put in, most recently, a bill that puts teachers' aides to help grades 1 through 3. Now, that's more for reading and things, but it's also to get help, right? So that there's some other people there to create potential touch breaks. But again, that's not going to be the answer. The answer is going to be that the fact is, in West Virginia, if it's not community programs, it's probably going to be in the school system, because these kids are being raised by grandparents. They're completely lost. They're out of touch with technology. They're lost. And so if we're going to continue to lose another generation or two, one of the ways we're going to have to figure something out is maybe to go in for that approach. But we just can't lay it on the backs of the teachers. It's a bigger task.
Hey, Bob Hanson. Yeah. What have you seen over your many decades of West Virginia that you would say we all need to know, that we all need to think about?
That's a hard question.
I know.
I don't. Just seeing the changes that have happened over the last 5 or 6 years, one of the things that we need to always be cognizant about is better collaboration and partnerships. I was looking on the web page where there were in Huntington and Cabell County, we have over 20 MAT programs, and we talk about isolated care and silos. We've had such a tremendous growth in treatment, but it's almost every program exists in an island, and we need to look, as I reflect back on this growth. I think a big thing is how do we break some of these silos down and work more collaboratively and more comprehensively to help our citizens. I think we've got, the growth has been great. People are moving into recovery. People are getting jobs, but I think we've maybe over-engineered our treatment and recovery system, and we need to take a step back and rethink some things.
Rethink some things like what? Don't think they're hanging out here like that.
We know recovery is a process, but our state, through Medicaid, funds primarily short-term programs or outpatient programs. We need more comprehensive, long-term supports for people. And part of that, too, is reunification and paying attention to families and parenting. So we need to rethink how we're delivering services to get better outcomes.
Now, how do we pay for all of that, Bill? Now, let's talk about the foundation part of this. What are the foundation's priorities? I know there's Exhibit E and what's in that. So, but tell the people about Exhibit E, because not everybody will know what that all is. Can you take 2 minutes or 3 minutes or 10?
Sure. So the West Virginia First Foundation is responsible for distributing the opioid settlement funds, or at least 73% of those opioid settlement funds. And we recently, as I think a lot of you know, we released about $19 million. And they identified 4 target areas that came out of Exhibit E. That's why I don't put the exhibit. Exhibit E. One was housing, one was youth prevention, we had one around child advocacy and parent women, and diversion in law enforcement, yes. So we had almost 200 applications come in, and so that really speaks to the need. And I think it also spoke a lot to where we need more service. This was about expanding existing services. We had a lot of regions and areas that we're in the middle of application gen, so it really spoke to what we need in terms of programs in different parts of the state. So a few years ago, I think it was 5 years ago, when our governor-elects came and talked to us about this MOU around the opioid settlement funds, they put forth this plan, and in that plan is Exhibit E, and has laid out 10 different focus areas for these opioid settlement funds. I would love to list them all off for you, but I probably would just mess it up. But they're the usual suspects, most of them. But it does offer a chance for us to invest in more comprehensive system of care that doesn't just end when treatment ends, because we know that treatment is important. Of course, it's important. But what happens after treatment is something that we haven't looked at as much. I think we're starting to. Has done some really good work with collegiate recovery, so educating people and supporting them as they go back and get their education, helping them get meaningful careers, and jobs they enjoy, reuniting them with family, teaching them parenting skills. There's a whole host of things that people have got to address. Criminal justice, and we're here tonight talking about some of the most important ones, their health issues. And so we're really hopeful that, it's exactly what Bob said. In a lot of places we have the system, but how do we get them working together and addressing these problems in a more comprehensive way? Now let me ask you a question.
I understand that your priorities were housing, sounds like housing diversion programs, as I think you said, housing diversion, women's programs, and you had one other. You had a you. So if somebody's going to send you a proposal to do this hepatitis C HIV work, what happens?
So, that's a good question.
Hey, that's why they gave me the job. Listen, that's why they gave me the job.
No, we are still working those things out for the foundation. Relatively new. We just got 5 people newly on staff, including myself. I've been there about 2 months. Jonathan, who's been on board for a lot more. John P. Bourne has been on board. And so there will be more funding cycles. I don't know exactly what that's going to look like, but we recently published on our website our direct funding policy. So there is a way now that you can bring some proposals and ideas straight to the board, and they can make discretionary grants as well. So that's now on our website. That is brand new. And they'll meet next week. I believe our board is meeting next week, unless anything changes, and I'm not in charge of that part. But and we're talking about some of those things.
Those are all open. I'll be here before you go. I mean, that plate of food ain't free. Because you had your hand up.
Well, yeah, that's not to say. Hi, everybody. My name's Crystal Good. I'm the founder and publisher of Black by God. I'm here with our managing editor, Tracy Phillips. And I've been waiting on a ring like this for a long time. Let me just pause and say, Bishop Haley, not all churches are like Pooch. That's a real church, and you've been doing the work, and it's a big deal. And I hope that you'll listen to my comments and maybe help me around this. So I've been struggling for a long time. Black by God is a news and storytelling multimedia platform. We do a print paper, and we do a print paper because, we got the Wi-Fi issues in West Virginia. And and we're online, works out. You've been around for 4 years. But what I have been asking in every room that I'm in, whether it's a journalism room or community room or this, who has told the story of how the opioid crisis has impacted the black community in Central Appalachia? Do your Googles. You won't find one story either, right? And to me, as I'm listening to this pandemic that we're having, the challenges that we're having, sometimes it's important to get granular, right? And also, when you tell a black story, the way we look at it in West Virginia, we're also targeting in the coalfield communities, right? Because those intersect. Black communities and coalfield communities intersect. So the story has not been told of how the opioid crisis has impacted the black community. And I think if you don't start there, right, then you don't understand the 3 generations that have been impacted. And I know, Bishop Haley, you can speak to this about the stigma around recovery for black people. And I can say, going through recovery myself, I've written about this, right? It is so white, period. I remember being in recovery, holding hands with people that have white power tattooed on them. Now, for that moment, in that recovery meeting, we are brothers and sisters. But I got pause, you know what I mean? And it's just not there. So I think the two are connected in how, especially black people, and Eric Geyer shared the numbers with me of black overdoses in the States. We're not even talking about this. It might be, it's very much to your idea of the opioid crisis. High numbers, small community, is something you should pay attention to. So I am very interested in anybody in this room that might be interested in helping us tell the story of how the opioid crisis and how it intersects with the solutions that I think this group of people, especially the First Foundation, all this stuff is happening. But Bishop Haley, would you talk about recovery in the black community and how the opioid crisis from your lens has impacted?
Yeah. I got a friend at Westfield School of Osteopathic Medicine, Dr. Hendricks. He came to me one day. He was down seeing Dr. Soto from Health Right. And he said, I got a question to ask you. He said, is all the deaths from blacks and he's talking about the west side of Charleston, did it come from health or did it come from gunshots? That's the mindset of people about the west side of Charleston, about us. And the thing of it is, we do a health fair, and we've proven that, number one, we're not taken care of like everybody else. Our medicine that we're given not necessarily is for us.
There's a whole lot of issues that go in there. And nobody really wants to say, okay, we need to look at this and make it change. We do have young people. We have recovery girls come to our church every day, Monday through Thursday. And they're there twice a day. And the majority of them are whites. And so I'm a nosy person at times. I just actually, they said, well, yeah, there's a lot down there, but a lot of time they remain locked up. So they don't get the same opportunities as these girls. And they come to these classes with the little ankle bracelets and everything else. We had one little girl, she bedazzled hers. But the thing of it is that I made this statement, and I don't want to offend anybody because that's not me. But growing up black in West Virginia is a mental condition. Because already you think that you're not adequate, and you're not good enough, and the only way you can get out of this situation, you got to be able to play ball, football, basketball. Now we're into soccer, and some of us into tennis. That's the only way we can get out. When I left in 73, going to the United States Marine Corps, was because I didn't see no hope here in Charleston. A lot of my friends that were there the day I left are dead now. And known about drug use, alcoholism, and the opportunity of going somewhere or finding somewhere to deal with their situation was not there. And then the stigma of us asking for help. I think there's not just a black situation. I think that's a West Virginia situation. Because I think people in West Virginia grew up tough. And we grew up just dealing with things. And we grew up not asking anybody for help. And so that's a mindset that we have that we've got to change. And so when we deal with our community, and, I'm sitting there sometimes 2 or 3 o'clock in the morning talking to people, talking them off the ledge, trying to find some place for them to go. And there's a lot of recovery units, situations out here that we can't get people into, believe it or not. We had a young man that came in there and he told us there's about 3 January to go. 3 years ago, he came here, it was mid-January, and he said, I've OD'd 19 times since the first year. And we had to call all around the state to try to find him a place to go. And I think we found somewhere in Ohio for him to go. And he couldn't go that night. His friend had to drive to there the next day. So our situation, and I, believe me, I'm not a woods, me personally, because, like I said, I'm a Marine, so I figured that I'm going to make the difference myself. But just dealing with our people and dealing with the situation, we got to realize that sometimes we have to help ourselves. We got to be that in our community. We got to kind of drum up, and we've looked around for different places where we can get help and get some assistance. But you got to realize, in today's economy, drug rehabilitation is big business. Money was dumped on the west side of Charleston. Companies that have been in existence for years decided to move to the west side of Charleston. And the people on the west side of Charleston are not even using these buildings because they don't trust them. There's a big trust thing with us, I was telling them we have a health fair. The reason I had the health fair, and I think it's the largest black led, even though we got people of other races in there, in the state of West Virginia. And the reason why we did it is because our people don't like to go to doctors. We're afraid of it. It's been embedded in us. My grandmother used to say, you go to the hospital, you're going to cut back dead. Well, I ain't coming back ever dead, first thing. Or you're going to wake up dead. That was always the good way. But that fear is because of people being in hospital, people being in offices, not getting back into the community. We got students coming down from the school, medical students coming down, interacting with our community. We see an immediate change. 2 years ago, we had 6 people there that were at high blood pressure that was critical. I mean, they could not have even made it out magic hour. They were that critical. We got them, the students at the Western School, Oscar at the Passing, took them, set them down, and dealt with them right then. We had health right. We had family care. We had all these groups. And if there's somebody needs to be talked to, I guess the main thing I'm trying to say is that you can't sit in your office and you can't sit in a hospital and think you can cure the problem of the community. You got to cure that in the community. You know, come on out, walk with us. Let's talk. Let's meet the people. And if you got a million questions, believe me, some of these folks sit there and try to answer all of them. We have questionnaires that we do at probably every food distribution. We just had a program where we took blood pressures. We actually gave them blood pressure cups that they took to their house. And they would take their blood pressure every day and bring the kids back at the next food distribution. They would get another. That's so we can get data so that people like you guys could, be able to use that. I don't know what to do with it, but I know you need it, And I know when we write grants, we need that information. And I told our partners, and like I said, we got some awesome partners, but CEG is one of the best. But the thing is, call us, get this information, put it out there so we can get help in our community. Because if we don't, we're not the ones with the pen that's going to write the checks. We're not. But some of us need to be, because they know what our community is going through. How about you?
So you bring up 2 really important and critical questions, and I'm gonna probably come to all 3 of you with this one. One is about the limited number of intermediary funders that are around. You're a community foundation. We know that we've got West Virginia First out there, but there are not a ton of intermediary funders or organizations that can do. We do small grants, but I've been shaking the dates to get that money. And money, I don't have those Megan Thee Stallion knees. I mean, I had to do what I got to do. That's number one. And then number 2, the other thing that you bring up is that you bring up the issue of how many of these for-profit corporations are coming in to provide services that are not community-driven and that are not from here. And if they're not from here, we know how it is. If you're not from here, we're not messing with you. So that's you. Go ahead, Mr. Big Mouth.
I'm not from here, so I'm sorry. I appreciate what you said, Bishop. I don't have an answer for that, Tony. One of the things that I do know and I've seen in my career is I didn't understand that lack of trust in the medical system, but it's real. And what I've learned, the area that I have expertise in is Memphis. And when I go to Memphis, I get to go to Memphis and work there. The people don't go to the doctor; they go to the church, even if they don't go to church. And so I had to start to build relationships there because it is about the community and doing that. So if we look at one of the fears I have about the overdose numbers, they're going down, and in our state they've gone down 30% month over month from January to June, except for one group, and that's blacks, and they're going up in blacks. And if you look at access to care, there's 1 in 10 people get help for addiction in the United States. If you compare that to diabetes and hypertension, the number is 8 out of 9. But that 1 out of 10 is if we're talking about white boys. If you're talking about anybody of color, that number, I don't even think we really know it, but it's got to be close to 1 in 30 or 1 in 40, and it's that distrust in the system. And so what I've learned is I have to partner with people who understand that. And one of those folks for me is Black Voices and Faces in Recovery. And what I've learned there, they have a toolkit that I'm trying to learn from to be intentional, because I used to think what you just said, which is a perfect example of it. Could you build it, they will come.
Yeah.
Not true. It's not true. It has to be intentional, and then there has to be trust built within the community, and really because of 300 years of generational trauma. And it only goes for blacks, it also goes for Native Americans. And so I think that we have to pay particular attention to that. We have to be intentional. And guys, I'm doing my best to learn, and I have to partner with those folks that can help me do that, which is what I'm trying to do right now. And so far I have been successful. And it's more my fault than anybody else's, but I'm interested in the conversation because my fear is that if you look at how we treated the crack epidemic in the 80s, we took tanks and knocked down walls and arrested black people because that was the inner city problem. We'll just lock them up. And now it's opioids, and he started out as a white issue, and we're going to treat it differently. And I think we have to own that because I think it's true. And then what are we going to do about it going forward? And that's why I like this. That's why I wanted to come tonight. I didn't know the bishop was going to be here, but I believe everything he said because I know he's right. And, you know, how do we do that? How do we be intentional about it? And I was very fired up, so I'm guessing you're talking about the DO school in Lewisburg that comes up, right? And I think that's they're all start to build bridges there, right? And for the students, they get to start to see that not everybody grew up like they did. And hopefully if they keep their eyes open, because that's what happened to me. I woke up one morning and, oh, my gosh, I'm living in the dream world. Not everybody lives in my neighborhood. And it's been eye-opening for me. It's also been good for me. And I'm still learning. So I don't have an answer to that, Tony, other than the fact that I'm willing to step into it because we have to do something. And those numbers continue to climb. So how do we do that? And I think some of the things bishops talk about is how we go about it.
I'm going to ask you a direct question that I've never asked it to you before. I know you're like, God damn it, dinner's almost served. Do you think you would have lost your license if you weren't white?
I don't know. I would tell you for sure I would have not gotten the treatment I got if I wasn't a doctor. I mean, and Tom knows this. I mean, it's what got me on this in the first place. When I was in detox, I was the only, nobody in there knew I was a doctor, and there were 24 kids on my floor, including me, and I was 35. The rest of them were youngsters. I was actually 36. The rest of them were youngsters, and I thought we would all go to the same treatment program when we left the detox gate. Only one person got to go to treatment after a detox, and it was me. And even though I was in the throes and withdrawals and shaking, that's when I saw that there's really two systems of care. There was the system of care that I got because I had resources and I had MD after my name. And there was this other system of care that people got that didn't have that. And it's really never left my mind, and it's what drives me today. So I don't think the fact that I was white was what drove it. I think the fact that I was a doctor is what drove it. And I think that my black colleagues who are doctors get the same treatment I do. We're not talking about that. We're talking about others. And so what have I seen in my community? I've seen black patients treated differently. And this even goes back to pain medicine. Back when, we were prescribing pain medicine, just haphazardly, we didn't prescribe it to blacks like that.
Right. That was like,
it was actually
right.
Right. And so I really think that we have to be honest about that, because I've never been able to start to fix anything until I got honest about how I got there. And I think we have to be honest about that. And I think we got to be honest about where we are right now. When I used to look at jails and prisons, well, there's a bunch of black faces in there. It's their fault. They did it so they got to know the time. That's how I looked at it until I got into it and realized that, I'm not subject to stop and frisk because I'm a white people. And actually, whites actually use drugs at a little higher rates than blacks, yet they're represented disproportionately in our institutions because of the system in place. And so I think we have to be honest about that so that then we can start to address it. And I'm just learning how to do that, guys, because my world changed 20 years ago when I opened my eyes and, like I said, realized that not everybody lived in my neighborhood, and I got special treatment. In my treatment, my progress through the treatment system was determined by the clinicians taking care of me. And what I've learned since then is that everybody else's progress through the system, first of all, it's limited. They don't get the treatment that I got for as long as I got. And then their progress through the system is determined not by the clinicians, but by outside forces that are paid. And I got some issues with that.
Right. Anybody have questions? Because we're coming up on 15 minutes, but I want to make sure. Yeah, I can't see your face, so I'm sorry.
I have a question. My name's Iris. I run the Farm Reduction Program at the Women's Health Center of West Virginia. I heard syringes mentioned a couple times tonight already. I'm curious how you all see the role and the value that harm reduction programs can have, particularly syringe service programs, in preventing HIV and hepatitis C, and particularly how that happens in West Virginia, where there's lots of legal restrictions to these programs.
Over the last couple of years, we've gone from about 18 above ground harm reduction programs now to about 8. I think that we worked our toughness off to preserve the 8. I think that, there are pieces of a continuing education that we need to do around the value of these programs. But again, I don't know that we've done enough to say or to talk about their value as it relates to HIV and hepatitis C in the psyche of people. I think that it's some of the same challenges we see with OTPs overall, right? Is that we think that people think it's one thing. You know, people think that, why don't you want more methadone clinics? Well, methadone is just another way for people to use drugs and treat pain. Well, that's not really what most people are going to a methadone clinic for, okay? And so I think that we also have to do a better job of educating people about what harm reduction is. And I think we have to be prepared for what I think is our new third rail. We don't often talk about the geopolitical climate that we're in. The political climate that we're in has not just started, in November, with this election. This has been going on for a minute about a more conservative bent. So we've needed to figure out new strategies of how to talk. But I think the other thing that has happened for some harm reduction organizations, both above and below ground, is that they stopped talking. They refused to talk. And if they didn't get what they wanted in the situation, the conversation stopped. And so what happened for me, is that there's some that would say we should have done X, Y, or Z. And I believe that in the state of West Virginia, we would have landed with 0 facilities. I think that the compromises that were made to land us at 8 were to preserve the 8. And I think that the thing is that I want to make sure that we are always in a position, and some of this is based on me and race and culture, but I always want to go in the front door. I'm not going to go in anybody's back door, so I always want to be able to have a conversation with a member. We are not always going to win, but that means I always still have to continue to talk. I always have to get some kind of if it's yes to you like the same socks, but I've got to be able to come back and have a conversation with you, because we have to figure out how we're going to get that number above 8, but I don't get that number above 8 if I stop talking. I don't get that number above 8 if I say to him, he's the worst person in the world, and then I wonder why he's not going to take a meeting with me in 6 months. Well, I kind of know why. We have to figure out the strategy to the long-term restoring of those organizations and institutions, and I don't know that we're there yet. I think that where we've got to do, but where we've got to be is that we've got to be an ongoing conversation, a dialogue. I think part of this conversation is that, part of understanding the role that harm reduction and needle exchange programs play in the elimination or reduction of HIV and viral hepatitis. The thing that we can do is also help understand how those folks play a role in PrEP uptake, but we've also got to be willing to design new systems to have new conversations. That's my input. Yeah.
I don't know if I can answer much better than that. That was pretty good. But I would agree with all the above. It's know your audience, right? So there has to be a balance there that's met. So when you've got legislators coming to town, they're talking about needle litter, and they're just, again, seeing the dark side of stuff. They don't see the positive side. I'm a big opponent of harm reduction. More so when the fight not only reducing HIV and hepatitis, but it's that touch point, and you've got to get as many touch points as you possibly can, as often as you can. And so when they come in there and you give them the option to get tested, when you give them the option for treatment, when you give them the options, and that's what you can use it. But at the same time, doing things responsibly, understanding that the community that you're in, that the others that don't understand this, when they do see a bunch of needle litter, when they do see, and I know there's communities with needle litter that does not have a harm reduction program, right? But when people knows that there's one in a community, they're going to be ready to point fingers. So you got to be cognizant of that, and understand that, and work with that community so that you're not creating a more uphill battle than you already have in front of you with all the challenges you have. And the other part of it is just the education about it. So all these data points and things they're talking about, we fought like crazy to get officer drug control policy lifted up. I mean, you look at any survey in West Virginia, what's really some of the most pressing things? Opioid use is always on the top. What have we done about the state? How have we funded it? How have we put a spotlight on it? What we have? I mean, so Rachel and all the guys that are here that's done all the stuff that they've done has been incredible for what the state has provided to them. So when we were splitting up the DHHR, I fought like crazy to make sure that we got off the drug control policy up to the level of the governor, and I tried to make as many dashboards to put as much spotlight on it as possible. We put language in there saying there has to be dashboards. So all this data needs to be collected into a central repository where the towns, the communities, the state governments, the counties can all see this and see what they're doing. So the hope is not to put a bad, but to highlight the successes of what this is actually doing. And when you see that and you see HIV rates go down, you see hepatitis, now the legislature is kind of handcuffed because they're like, they can't argue with success. But if they don't know it, they're not educated, they'll see it. It's hard to get them to fund it. It's hard to get them to buy in on it. And the only way we're going to do that is the data and education. So and you go back a couple of years ago and you look at those bills for the data, I want to be able to pull up sites and know where's all the money. Where's all the money that's been sent to the counties, the municipalities? We know West Virginia First Foundation has it. And what are they spending it on, right? So the other thing is the Office of Drug Control policy needs to be helped directing that with data to tell these communities what to do so that they can tell these three surrounding counties or towns or municipalities, whatever, you don't have to spend all of it. Why don't you guys take some, and you guys take some, and you guys take some, and create a harm reduction or whatever program that this community is going to benefit from, because look at all the other communities that's very similar to yours. Look how they benefited from this. And those are the ways we're going to finally get this going. It just unfortunately takes way too much time.
I think you're passing it because of how you feel about needle exchange, and I know one of the first conversations you and I had.
My whole deal is this: is I'm all about people being accountable. Held accountable. I raised 3 kids, and one of the first rules we had: number one, you don't lie, you don't cheat, you steal. Then you don't never quit. Whenever you start working at, you do that. I found out, and dealing with people on the ground right there at the church. If you tell them what your expectations of them, then and then you hold yourself accountable to things. Most of the time, they're not going to fail you. There's always that chance. There's always that relapse. But when you relapse, I don't throw you away. I just re-engage with it, get it back together. And I don't know enough about the program to say that it's a blanket, it covers everything. I just think that we got to hold people self-accountable. We feed people monthly, but the thing of it is that we're also teaching them how to budget their funds. You buy this, you buy that, you pay this, you pay that. And then when you come in and buying, that's where we're at. You know where we're at. We're here and if you need me throughout the month, I'm there. That's my big deal, is that I don't think in a lot of cases we hold people accountable. They're intelligent people, and I had a guy that went to our church, but before he came to church, he had a $700 a day habit. I ain't never made $700 on Monday. Never. And he always was high. And that's what I'm saying. So if you put the ballpark and they say, okay, you come here, you get your needles, but all the time you got to be working your way off this side. You got to be working your way out of this. Not just, this is a free for all, you come in and get what you bought. Stuff. So that's you and me, man, and nobody else.
First of all, the bishop said pass. I didn't know that was an option.
No, for him it is.
So I'm not a death status. I want to talk about what the bishop was talking about. And it's this. A lot of times in addiction, and we look at it from the outside, and we think what we would do in holding ourselves accountable as rational human beings, and that's not what we're dealing with. So I'm going to go see Fish. We're going to talk a little bit about addiction. Because in addiction, we lose access basically to the frontal lobe of our brain, which gives us insight to judgment and empathy. And we're driven solely by the reward center of our brain. So I want everybody in the room sit here and think this for a second. What would you do, or where would you be, if the only impulses you paid attention to were the ones that brought you pleasure? And the answer to that is all of us would be in jail by noon. And so that's what happens in addiction. I made more money in a year than my mom and daddy made in 10 years combined in my own addiction. Yet I stole from it as a doctor. I sat outside of a pharmacy in Alabama with a loaded gun in my lap as a practicing physician and professor of the medical school and contemplated strong-arm robbing a pharmacy. That in no way matches where I was in my life, other than it's perfectly explained by addiction, because I thought I would die if I didn't have the thing that was inside that pharmacy, and so I was willing to do anything to get it, like your guy there, to carry it out away and get $700 today. Yeah. Right? And so you get people who otherwise, with their brains functioning properly, would be just fine, but now they don't have access to that part of their brain that gives them insight and judgment, and they think they'll die without this thing, and their craving for it's 10 times stronger than our cravings are for food when they're hungry. And so now we can start to understand behavior a little bit. So when I started to understand that, Bishop, because I saw it in my own life. I would have told you the most important thing to me was my wife, my kids, when the reality is the most important thing to me was this. And then when I had that, then I could have this. And so when I understood that, then I started being able to work with people. And I'm with you on accountability. That accountability will come as the brain recovers, so we can talk about that. Yeah. So when you're looking at harm reduction, I agree with what Tony and Senator said, that these are positive. My friend Jan Rader talks about this, positive touch points. You do it all the time. Food, however you get them in there, you do it, right? And so this is an opportunity for a positive touch point. I don't think people understand in harm reduction programs. One of the most often asked questions is, how do I get help, right? And that's a really good thing. And our legislators need to be educated on that, understand that. And just like Senator Takupo said, it's one of the reasons I'm here in West Virginia, is taking this data and being able to show, what kind of impact we're having and what that means downstream. In the cases of HIV and Hep C that we prevent because we provided this, it's not just about finding needles on the ground. We find those anywhere. And so understanding that, and then how that touch point, that positive touch point, leads to somebody getting help. I tell people all the time, when I got treatment, I didn't go to get recovery. I went to save my medical license. As a fact, I got recovery, right? And so those positive touch points, the more times that we can do it. People are two varieties in my experience. Some are the bright light variety, and others are the slow drip variety. And to me, when we have those opportunities at things like you do at your church, things like new exchange programs, jail even, these could be positive touch points in helping people find their path to recovery. And so that's what I believe in. And I believe the harm reduction programs do work. I believe they're a benefit. And I think we have to be able to show that to our decision makers, who I know for a fact don't want to hurt people.
I mean, ditto. So a lot of what I've heard, but we have the data, we have the education that we need to get out, but also we have so many of community members and organizations that have the same mission and the same values that aren't working together. And I think, we have the power to change that narrative and hopefully find ways to be the ones to tell the story, to make that change, to get to those folks that need to hear it, that we can have the community accept what we need to be healthier and change our systems. So I know it sounds easy, but we all do.
And I don't think you're asking for it to be easy, but I think you're asking for to make sure that we bring it into the room and speak it into the room. So I appreciate that. And first of all, I want to thank you all, but the last thing I want to do before I let you go for dinner is, Brandon, can you kind of turn the camera around? And I want to go table by table and figure out who's in the room. Who's in the room? Who are you?
Mary Tierney. I work with SOAR West Virginia, and I'm from West Virginia.
So Jill is it alone? Hi, Katie Coyne. I'm a reporter with West Virginia Watch. I've been covering the drug epidemic in West Virginia for about 7 years, and very excited to be here and hear this conversation evolve.
Iris Siddickman. I'm a social worker, and I run the harm reduction program at the Women's Health Center of West Virginia.
Service. Next table.
I'm Christina Bickers, brand new outreach and education coordinator with West Virginia Drug Intervention Institute. UECIT.
Oh. Expert and the grants administrator for West Virginia DII. And we do know some one boxes. They're
What are those?
They are, it's what we generated earlier.
This is our one box. We can supply you with a Narcan or naloxone or Revive, whatever we happen to have on hand, if you're here in West Virginia. But what it is our self-treating box. First off, and Jan will lead you through how to train the naloxone. I'll stop that. It does come with PPE, and again, it is designed to hold up to 2 boxes of naloxone, whatever brand we want. We do have some here that have already been paid for grant programs, through our grant program. If any of your organizations are interested, just come back and see us. We'll wrap up. Thank you very much. All right, who's back to the last two?
Yeah, I'm Jonathan Young. I work at Health Affairs Institute at WVU, and I'm an assistant director for mental and behavioral health.
Yeah, I'm Bob Hansen, and I'm right now the interim co-director of Recovery Point West VD.
That's real, the Kylo.
I am Michelle Thayer. I am the hepatitis C peer navigator for Marshall University in Bourbonnais County, West Virginia.
Susie Hollins. I'm the program director for the West Virginia Collegiate Recovery Network, and also PI for the hepatitis project, along with co-PI.
And I'm Carissa Warner. I work at Marshall University as well. And what we're doing goes right in with everything else. We have peer navigators within the community who are meeting people where they are, that our peer navigators have had their own experiences with Hep C, and we provide education, because one of the things we have found out is that people are afraid because of the old interferon treatments, that there is a cure. They go to the doctors with them and set them up for the appointments, they get treatment. And we also have an incentive where you get a $25 gift card for being tested, and if you need the testing, and you get treated. When you finish your treatment, we also have an incentive into treatment. And we're also doing a media campaign. We're trying to get faces of individuals who have experienced this so that people understand this is something that it can be your brother, your sister, your cousin. It doesn't have to be the face that we've always put on. So.
Well, who's that phone when I speak?
Joe Deegan. I'm with WVU Medicine Thomas Hospitals, and we have the Addiction Healing Center at St. Francis Hospital. I'm a business development liaison and also public policy chair for the addictions professionals in West Virginia. And Susie and I are on that board, or together. So we have a day at the Legislature Recovery Advocacy Day coming up March the 7th. So hopefully we'll see some of you there.
Who's at the back? Josh? Where
Jason Lucas, I'm the change program lead at Community Education Group.
Perfect.
Hi, everybody. My name is Nick Stuchel. I am the Inter-Commissioner of the Bureau for Behavioral Health at the Department of Human Services. And in my free time, I'm also the General Counsel for the Bureau for Behavioral Health and the Office of Drug Control Policy. And Dr. Lois, we keep more of this.
Uh-oh.
I'm Phil Schoen. I'm foremost, I guess, a person in long-term recovery myself, former Medicaid commissioner and dirty word lobbyist for both the Addictions of Professionals and the Alliance for Recovery Relevance.
Very good. Appreciate you.
Hi, everybody. I'm Crystal Good, founder and publisher of Black by God. And you all have your phones, so you could just go to blackbygod.org. And we've got wonderful stories about CEG, the work that they're doing connecting Appalachia to Africa. Very similar, same conversation. Also have stories that we try really hard to feature as many like BIPOC healthcare professionals as we can to start to bring down that stigma. And we have a wonderful story about Heather Robinson. I'm not sure if you all are familiar with Heather and the work she's doing, hepatitis C in Southern West Virginia. So please follow Black by God. We're working really hard to get information out, and would appreciate it if you would share, but also share. Share your story. And I'll let Crazy introduce herself. So, yeah, she's the one still answering.
Yes, share your story, please. As Crystal said, my name is Tracy Phillips, and I'm a project manager with Black by God. I have a bachelor's degree in broadcasting communications, have my hands in a little bit of communications in a couple of different areas. But in addition to my background in communications, I'm also a small business owner here in Charleston. Myself and my husband, we own a business called Fun Fitness Kids Club, with West Virginia leading the state in adult and childhood obesity. Not the state, the country in adult and childhood obesity. We just want to bring some fun with fitness. So if you're looking for some fun for your babies, specifically ages 0 to 4, for any of these events that you all are planning, we have some fun for adults. We work with WVU and Thomas. We bring our 360 photo booth for adult galas. We're in the community with schools doing obstacle course challenges. So we're always looking for fun and innovative ways to bring fun with fitness to agriculture, to recovery, to anything that you can think of. So like Crystal said, please look us up, Fun Fitness Kids Club on Facebook. And we're here to bring the fun.
Plug it up. Yeah, plug it. Change my kid's face. They look. The positive heroic. Excuse me, Mr. Behind the camera. Who are you?
Sorry, I'm Brandon Miles. I wanted to do it. And I'm the communications manager at CEG.
Perfect.
Everybody, these Soro external affairs and.
I feel like I should stand. Hi, everyone. My name is Labina. I am the new policy director at CEG, so I'm happy to be here.
Very good. I want to thank you all for taking the time out of your busy schedules to share a bit of conversation with community. We're going to be posting this on YouTube and also on Facebook and Instagram and the Talk of the Ticks and all of the things. But again, thank you. And this is an ongoing conversation, not an ending conversation. So again, thank you so very much for everything that you do.
Thanks so much.